Very good morning to all of you. This will be the outline of the presentation. We'll go and see what is the definition of autonomic dysreflexia, what are the causes, and how is the autonomic nervous system controlling the blood pressure, so that we understand the pathophysiology of this medical issue and how to manage this issue. I think most of them were third year residents, so by this time you must be aware. So it will be like a question and answer session somewhere. So you try to pitch in with some answers if possible. And how to manage recurrent ADs and what are the special precautions in some specific situations or activities that can precipitate AD in high risk population. So what is autonomic dysreflexia? This is the definition that is provided by the international standards for documentation of remaining autonomic function after spinal cord injury. So autonomic dysfunction is a constellation of signs and or symptoms in individuals with spinal cord injury. So it is very commonly seen in spinal cord injury, but when you look at the causes, there have been reports in literature as other causes of, other than spinal cord injury, there are some causes, relatively small amount. And these occur in spinal cord injury lesions at the level of T6 and above, and we'll soon see why. And that is because of the way the autonomic nervous system controls the main organs, that is the heart and the blood vessels. And in response, this is in response to a noxious or non-noxious stimuli. So this response is sympathetically driven, it is also life-threatening, and it is uncontrolled. So that is the problem that we have in autonomic dysreflexia. And this stimulus arises mostly from the level below the level of injury, and it is defined as an increase in systolic blood pressure. There is no absolute value, it is an increase in systolic blood pressure from the baseline. And this value differs in adults and in children. In adults, it is more than 20 millimeters of mercury, and in children, it's around 15. So this is autonomic dysreflexia, and as I said, other than spinal cord injury at the level of T6 and above, in literature, it has also been reported in other medical conditions like Guillain-Barré syndrome, traumatic brain injuries, due to some medications like adrenogenic medications, sometimes illegal drugs, the use of illegal drugs like cocaine and amphetamine, and also subarachnoid hemorrhage. So the autonomic nervous system, how does it control the blood pressure? So the most important is the medullary center or the vasomotor center, which controls the blood pressure as well as the heart rate. And this is controlled by the cortex through the hypothalamus. That is, the mood or emotions can control and drive stimulus to the hypothalamus. And that is why when the person is anxious, again, the pulse rate and the blood pressure can vary. And the autonomic nervous system basically is the parasympathetic and the sympathetic. The parasympathetic is arising at two levels, one at the medullary level through the cranial nerves. It distributes to the several organs. And in this particular context, we are really seeing that it is distributed to the heart. But you can see that there is no parasympathetic control to the blood vessels. The blood vessels is purely controlled by the sympathetic nervous system. And the sympathetic and another parasympathetic system is at the S2 to S4 level, but not in this context, and hence I have not mentioned here, and that controls the pelvic organs like the bowel, bladder, and the sexual organs. And then there is a sympathetic system which drives from T1 to L2. And that all along is again through their postganglionic neurons, controls the heart rate, the heart, as well as the blood vessels. Now there is at the T5 level, the sympathetic system up to the T5, that is T1 to T5, they send control or the blood vessels to the upper limb and to the upper aspect of the body, whereas those that D6 and below basically control the splanchnic circulation, the blood vessels inside the splanchnic circulation, which is the major blood supply, which is the major determinant of the blood pressure. And that is why we see the blood pressure is drastically increased, and hence why the level D6 is important, because below the D6 is where the sympathetic innervation of the splanchnic circulation occurs. And at the medullary level, there are different centers, and they are controlled by afferent receptors. These are the baroreceptors, and they go to the nucleus tractus soleus, and this controls the parasympathetic through the nucleus ambiguous and the sympathetic through the several ventrolateral medullary systems, and there is outcome. Now the medullary, in the pathophysiology, you can see when there is a stimulus below the level, and as you have already seen, as told by Matthew sir, the most commonest is the bladder, two Bs. The bladder and the bowel, they are the causes for almost 95% of the ADs. And this stimulus leads to the sympathetic drive, and there is increased contraction of the blood vessels in the splanchnic circulation, leading to hypertension. And this hypertension is picked up by the baroreceptors, and this, as you said, as you saw before, the baroreceptors, the baroreceptors control the nucleus tractus solitarius, and this in turn drives the vagus to reduce the pulse rate. It also sends an inhibitory signal to the sympathetic centers. But unfortunately, what happens is the message from this sympathetic center in the medulla is cut off at the D5 and the D6 level. So it never reaches the splanchnic circulation, and this uninhibited life-threatening sympathetic response continues, and thus leads to several symptoms. So proceeding further, there are also other pathophysiological mechanisms, and that is an increased activity, hyperactivity of the adrenal medulla, and also the upregulation of the peripheral adrenergic receptors has also been reported in spinal cord injury individuals, resulting to the excessive increase in blood pressure in this patient population. So what could be the differential diagnosis? Sometimes the person can present with such symptoms, especially in the emergency medicine department. Sometimes there is, so you must keep your eyes open always for the DDs. There are other conditions which can also mimic something like autonomic dysreflexia. These include conditions like carcinoid syndrome, neuroleptic malignant syndrome, pheochromocytoma, serotonin syndrome, and the thyroid storm. So it's important in the context to also keep your mind open to establish other causes of that can lead to conditions, excessive hypertension, etc. Now management, I have referred to only one, and that is the standard, the VA guideline for the management of autonomic dysreflexia. So we saw that it is present at the D6 level, and how do you recognize these symptoms? Now these symptoms are classically driven by the sympathetic response. Above the level of lesion, there is mostly the parasympathetic drive, and below the level of lesion, there is a sympathetic drive, leading to several symptoms like, and the most important and the commonest being the sudden and severe pounding headache. And then there can be bradycardia related to the baseline, but there have been reports wherein tachycardia has also been reported. And this is because how in person to person in spinal cord injury individuals, how the heart response varies, the distribution of the autonomic nervous system and how much it's able to control also varies. So don't depend only on bradycardia. It could be bradycardia as well as some tachycardia also is reported. The patient may be anxious, and there may be nasal congestion, hot flushes, cold and pale skin below the level of injury, and piloerection. And the symptoms marked in bold are the one that you have to look out for, because you are now facing a life-threatening situation, and probably you transfer the patient immediately to the emergency medicine department. These include respiratory distress because maybe the pulmonary edema is developing, blurred vision developing because of the retinal detachment. There can be seizures, arrhythmias, sometimes leading to myocardial infarction, and cerebral hemorrhage. But always remember, there may be some situations wherein there will be absolutely no symptoms, but the blood pressure may be increased, and such situation is known as silent autonomic dysreflexia. And that is why when you look at studies epidemiologically, how much autonomic dysreflexia is seen, if you see those that have symptoms, usually then the incidence report is quite low at 20%. And when some ambulatory BP monitoring apparatus is used, suddenly the incidence shoots up to 40 to 70%. So it depends upon how you are studying this. And it's important to recognize this condition because these persons are also equally susceptible to life-threatening situations, and it's important to identify such situations and suspect them and treat them. So now we have diagnosed that suspecting that this person based upon the clinical signs and symptoms. So what do you do next to prove that this person has autonomic dysreflexia? Measure the blood pressure. Good. So to measure the blood pressure, it is important that in spinal cord injury individuals, the baseline blood pressure, especially in these patients, that is at the T5 and above patients, is quite low. This is where the non-PMR specialists have to be sensitized, and that is why even the patients have to be educated that hypertension or the what is considered as normal for a normal person will be actually be detrimental for these individuals. So the expected baseline pressure in these individuals is around 90 to 110 millimeters of mercury, and any increase in baseline by 20 in adults and 15 in children is to be labeled as autonomic dysreflexia. So it is important that you know that measuring the blood pressure is crucial. So how to measure the blood pressure properly? You must be, as residents, you must be thorough in this. Use the proper cuff, otherwise you're going to have false high values and false low values. You are going to miss a life-threatening condition. Use proper cuff size and length depending upon the age of the patient and the arm circumference. Decide the cuff and measure the blood pressure. So now that you have measured that this person has autonomic dysreflexia, there may be some conditions wherein the person has symptoms, but there is no blood pressure. So it doesn't have autonomic dysreflexia. Then you involve the other medical consultants in order to identify what is the cause. Investigate further to find out what is the cause for those symptoms. But if he has autonomic dysreflexia, as a point to be discussed here, what do we do next? The first thing to do is sit the patient upright immediately. Don't search for cause. Once you have diagnosed, if he is lying down, immediately sit the patient up. The BP drastically falls down and falls down by almost 10 to 20 millimeters of mercury. And the rationale behind is that because there is going to be pooling of blood in your lower limbs, leading to immediate relief in probably symptoms, and also loosen all the constrictive clothing. Because another common cause or the triggers for the autonomic dysreflexia in these patients is tight clothing, sometimes tight straps, NADA, tight belts. Sometimes the urinary bladder is wound tightly to the legs, which is a common thing for these patients, but and it is under the garments, binders which are inside the garments, and stockings inside the garments. Note both visible as well as those under the garments. These can also precipitate autonomic dysreflexia. So sit the patient up and look for all this. Easier to do interventions to bring the BP down. Next what? And the BP is not coming down. Ask the patient whether he took some medications that can cause this problem, because in this group of patients, the orthostatic hypotension is also a common problem, and they may be prescribed some medications which can increase the blood pressure. It can be like midodrine or so, etc. So find out whether they took some medications that can cause these issues. So now you have found out that this person has not taken medications, but his blood pressure is really high. And mostly in the rehab-like situation, you are dealing with persons who have already been off the indwelling catheter, which means he's doing CIC. So there is no indwelling catheter. So what do we do next in such patients who have doesn't have the indwelling catheter? You have to catheterize them. What do you do before you catheterize them? Check the BP again. The BP has to be checked at every 2 to 5 minutes. And if the BP here, this is arbitrarily determined levels for start the medications. So if it is above 150 milligram of mercury in adults, or depending upon the age, if it is 20, 30 or 40, start the medications. And the important to choose the medication is it has to be a rapid onset and short duration of action. Why? Because autonomic dysreflexia are highly fluctuating. It comes and hits and then it becomes normalized again, and therefore we need medications which is rapidly acting and short acting. So these are the list of medications depending upon the situation of availability, the ease of comfort with which you are able to use it, you can use. Most commonly we do use the nifedipine, which is quite at the bottom, which is used by the bite and swallow method, 10 milligram. Why? Because the sublingual route is unpredictable how much the dosage is taken. So usually 10 milligram bite and swallow technique is given. In some Western countries where nitroglycerin 2% is easily available, this is also preferred. This is usually applied as a 2-inch ointment, usually at the above the level of lesion, because the rationale behind is that because above the level of lesion, the vascular flow is going to be higher during this attack, and therefore the absorption is going to be easier. And another advantage of nitroglycerin is that as soon as the blood pressure drops, you just wipe it off so that there is no more action of nitroglycerin, so that the patient does not go into hypotension. And also important to see in this context is that they have not taken any phosphodiesterase inhibitors, otherwise there is going to be life-threatening hypotension in these individuals. So there are some medications like captopril, clonidine, hydralazine. So choose whichever is easily available and which you are comfortable with. And if in resistant cases, go for intravenous form of medications in those who are not responding. Also, you can shift to the emergency medicine department and go for intravenous medications like hydralazine, which are even more immediately responsive. So now you have given the medications, and then making sure that it is well below that 150 level, you catheterize the patients, but again take due precautions which you usually follow. Give lidocaine, adequate amount of lidocaine, and make sure, and then you insert the catheter. Wait for 4 to 5 minutes after you intraurethral inject your lidocaine medication. And now there is no, after inserting, let's say, there is no voiding of urine. What do you do next? It's don't go and press the bladder suprapubic pressing or suprapubic triggering. This is the usual thing that you will do. Don't do that. This is going to even worsen the autonomic dysreflexia. Most commonly, it can be blocked by the lignocaine jelly itself because we are applying. So apply a little bit of, flush it with a little bit of normal saline to open the blocked catheter, and the urine may start draining in such patients. So if it doesn't, in some situations, they are still on indwelling catheter, then what do you check? You check the urobag. Sometimes the urobag is full and there is a back pressure, and then it can trigger ADs to make sure, which is very, very less common nowadays, but always do that. You never know. Check the urobag whether it is drained out, and then check whether there is urine in the urobag. If there is no urine, check the tubing, whether the tubing is kinked or something, because I have actually seen as an intern wherein it was kinked and the patient was yelling in pain. It was not a case of spinal cord injury. It was a simple, he was lying on the bladder, he was lying on that tubing, and it was kinked, and there was a call for me. All I had to do was shift the patient, unkink it, and the urine was flowing out. So unkink the tubing. Now you have unkinked the tubing and still there is no drain. What to do next? You suspect a block. So how do you remove the block? You again flush it with normal saline. What is important to remember at this context is that normal saline has to be at body temperature, because anything that is cold is going to again trigger and worsen the autonomic dysreflexia. And some in this specific guideline they have mentioned that if available, use a lidocaine solution, because then irrigating it may be beneficial by decreasing the sensory input from the bladder. So it could be a body temperature normal saline, and how much amount to use is also important. Don't use too much volume, again that may be worsen the ADs. It is just 10 cc, 10 to 15 cc in adults and 5 to 10 cc in children below 2 years. 2 years and above is 10, less than 2 years, just 5 to 10 cc. So you have done this and still it's not coming, which means the catheter is definitely blocked. And then which means you have to remove the catheter and change the catheter. At this point, if the patient is coming up, please do remember that if you have difficulty in removing the catheter, then start some medications before changing the catheter, in spite of the blood pressure not being above 150. This is because difficult to remove catheters, during when you are removing it, it is going to cause even much more irritation and the BP is going to shoot up. So this guideline recommends whenever you deal with a difficult catheter, always start some medication or keep medication handy. Then you go ahead and change the catheter. Again, the process for changing the catheter is the same. And even more, if it is difficult, take a consult from urologist or shift the patient to the emergency medicine. And now when you have ruled out the urinary bladder problems or any bladder symptoms, next commonest cause is to consider bowel. And in bowel, the most important are constipation and the fecal impaction. And most immediately to relieve is the fecal impaction, because in constipation is going to take time to relieve. So fecal impaction has to be suspected next. So you have now considered fecal impaction before checking for fecal. Remember, the patient is now upright, sitting upright. You have made him upright and you have done all the testing. You are checked with the bladder. Now, before bringing him down, because to check you have to put him in the left lateral position to check for fecal impaction. Check the BP, make sure that it is below 150. If not, start medications. Then put him in the left lateral position, check for fecal impaction. And just like you do for the Catheterization, here also you put adequate amount of lidocaine jelly, wait for adequate amount of time like 4 to 6 minutes, 5 minutes or even 10 minutes, and then do the disimpaction. During the disimpaction, again monitor the BP, because the BP can again rise, and if it rises, stop your procedure, wait, give some pharmacological agents, or wait for some more time, or increase the amount of lidocaine jelly, and then proceed with the disimpaction. So now you have disimpacted, and when you see if there is an impaction, and when you check if there is no impaction, what do you do next? These are less common causes, which are probably 2% of the cases. What are the other causes of triggers? In the same guideline, almost 50 different causes were listed out. Please go through them one by one, but some of the commonest I have illuminated here, and these must be at your fingertips, because you have seconds to save the patient. So autonomic dysreflexia is one of the fewer emergencies that you are going to deal with, and hence in the Viva, you are expected to know everything by heart, step by step, and these are mostly guidelines and in your fingertip, because it is a life-threatening condition. So the list out and rule out the lesser but easily amenable causes. And still, if you're not able to do or manage or find out the trigger, you're not able to BP, shift the patient immediately to the emergency department. And then what? Now you have successfully dealt with autonomic dysreflexia. Your job is not at over. After the BP is controlled, monitor the patient for at least 2 hours. Why? Because a second or another multiple episodes can come back, or because you have used some pharmacological agents, the patient can dip into hypotension. And in such cases, you may have to give some intravenous fluids to bring the BP up, etc. Record the event medically in your medical record. Teach the patient and the caregivers the reason and how to deal with this problem in future, and provide a written valet or card, so that the patient, if he has this in future and when he has to approach some other person, a physician who is not who is not comfortable with you doing it AD, he can easily recognize the symptom and intervene as per the available interventions. And then there is a problem of autonomic dysreflexia. This can be due to several features wherein we are not able to immediately treat the problem. This could be like skeletal fracture. You are not going to be able to remove the fracture immediately. It's going to take its own time. Pressure ulcers, it's going to take its own time. Other than offloading from the pressure ulcers, sometimes it reduces the BP, but sometimes if it's some other problem, like heterotopic ossification, then the AD is going to be persistent. In such situations, the most important is to establish a proper bowel and bladder program, so that there is no another driving trigger, and start some medications. The medications are basically, there it was short acting, here we prefer a long acting type of medications. And as per one study, this survey, they found that clonidine is most often preferred by the clinicians, this being the easy to administer dosage regimen, that is once daily or a weekly regimen, and also because not only it has anti-hypertensive effects but also anti-nociceptive, because pain is also another trigger. And also they have been using analgesics, even though it does not give directly in the pathophysiology, does not impede. This has also been commonly been prescribed, but less prescribed in this patient population, of course, is prazosin and terazosin, which is often also can be given, but always many clinicians had inhibition, because in this particular subset of population there was increased use of phosphodiesterase inhibitors, and then it can lead to life-threatening hypotension. So choose, depending upon the situation, whichever medication you have to use in such cases. Then there are some particular precautions that you have to follow during some particular activities or intervention procedures or situations like pregnancy in highly susceptible individuals, and how to suspect them. You are supposed to know from the exam point of view also. This could be like sexual activity. Again, it can precipitate the AD. You must educate the patient how to deal with it, immediately cease the activity and follow the AD protocol. And sometimes you can use even prophylactic medications in such situations to manage with the ADs. And sometimes because of the silent AD post-sexual activity in these patients, there may be increased blood pressure leading to silent autonomic dysreflexia. So highly suspected individuals, ask them to measure the blood pressure after such situations, like even changing the catheter, doing CAC for the first few days to see whether they are actually having ADs or not. And another problem is usually you do some interventions like cystoscopy and urodynamics. These are common urological procedures. Plan them so that you're not doing along with ADs. If you're suspecting on the day, ADs on the day, this cystometry is planned, abort the cystometry, plan it on some other day. And when you are doing the cystometry, monitor the BP regularly. The only difference in protocol here is that wherein normally in ADs, in normal, you immediately sit the patient up. In these situations, you are doing some intervention, immediately sitting the patient up is not possible, and therefore you start immediately the pharmacological agent before you give some before you seating the patient up. That is the only difference in such situations. And another important is the pregnancy and then in sports. In pregnancy, AD is not just seen in labor. It can be seen anytime during the pregnancy, and the most common is in the third trimester of pregnancy, during the child labor, and also post birth, during breastfeeding, breast engorgement, mastitis can also precipitate AD. So expect it at any point of time. And these are high-risk individuals. They'll require weekly monitoring of both the mother and the fetus from the week 28 onwards. And again, during the labor, the spinal anesthesia or the epidural anesthesia is favored. And it is important to differentiate AD from preeclampsia in these patients. And that is most important is the triad in preeclampsia of not just pedal anemia and hypertension, but also proteinuria, which usually helps in differentiating between the two. And also the hypertension in AD is episodic during the uterine contraction, whereas in the preeclampsia, it is present throughout. And finally, going to sports, again, boosting is illegal by the International Paralympics Committee. And the boosting is why it is used, because these persons at T5 and level and above, they have low cardiac output, low heart rate, their ability to perform is affected, and therefore they use this strategy. They trigger it by sitting on the scrotum or breaking their toes, or by clamping the Foley's catheter if they are having Indwellis catheter, to boost the BP, to boost the adrenergic drive, and that is illegal. And in fact, the cutoff BP is 160 mmHg. If this level of BP is present, then they are not allowed to participate in sports further. And this is important again as educating, especially your when you are taking in recreational activities or in even Paralympic sports events. So to summarize, autonomic dysreflexia is a life-threatening, uncontrolled sympathetic response triggered by a noxious stimuli, usually seen in spinal cord injury individuals at T6 and above, diagnosed as a rise in systolic blood pressure above baseline by 20 millimeters of mercury in adults. And bladder and bowel are the two most common triggers. And when you see them, identify the triggers and manage the triggers. And use medications only if the systolic blood pressure is higher than 150 millimeter of mercury in adults, and look out or use precautions in high-risk individuals during pregnancy or sexual activity or before performing urological procedures and during sports. Thank you.
Sir, I want to know what's your opinion with detrusor sphincter dyssynergia and AD and the medications like alpha-1 blockers which we use.
Detrusor sphincter dyssynergia is a cause of AD. In fact, in recurrent AD, the worsening of DSD has been, you have to detect it, you may have to perform the USDs. In such situations, the alpha blockers are usually preferred because they manage the DSD as well as the ADs.
Sir, like common alpha blockers like prazosin or like alpha-1 selective blockers like tamsulosin?
Both have been used. There is no randomized control trial comparing these two drugs. In fact, most of this guideline is based on a level 3, level 4 evidences, not based on level 1 evidence randomized control trial. So you can use any medication of choice.
Thank you so much.
Just a comment on the GTN being used. We use it as a spray sublingually. That's the most commonly and easily administered stuff. And it's very short acting, so it doesn't really cause you any problems. If your BP goes down below a certain level, just lie the patient down. That's the way to manage it.
Yes.
Ideally, it is a GTN spray should be used.
Yes.
Not the ointment.
Not the ointment, yes. Yes.
His question on DSD and very small spastic bladders. which cause recurrent AD, I think the level of evidence for intravesical neurotoxin is pretty good.
Yeah.
So patients who you have diagnosed to have severe DSD, small bladders, spastic, and you have ruled out all other causes, the evidence for intravesical botulinum toxin, if we can
Botulinum
afford
toxin,
every 6 months or 4
Yes,
months,
true.
is
Botulinum
good.
toxin and sphincterotomy have also been tried in
Yes.
such situations. Yes.
Does anyone know whether GTN spray is available here? I've tried to get it and it's not possible to get it. It's number one. Dantrolene is not available in this country. Two things that are really terrible. I think these are essential drugs to be available in a patient population like cord injuries.
It is a very good presentation by my dear colleague Srikumar. For the benefit of PG students, see, it is very often that autonomic dysreflexia will be asked either as a short note in the theory paper, or if you are given a long case of spinal cord injury, you are likely to be asked about this in that situation also. So, although Dr. Srikumar has very nicely presented what are the recommendations and the guidelines, in real life situation, it is not so easy to implement it, because this kind of step-by-step coordinated action requires at least 3 people, and the 3 people should be very conversant with the protocol and the steps, and they should have practiced it before the actual event is brought to their notice. Unless there are nurses involved in the training, because they will be more often the first person to detect the occurrence of autonomic dysreflexia, physiatrists will be relatively late to come into the picture. Although it is important for physiatrists to know about this condition so that they can do the coordination and the leadership role in that team. And many times it helps to train or alert the relative of the person who is more often with the patient before even the nurses come into the picture. So I feel it is important to be aware of the real life scenario, and they need to be trained. In UK, I am aware that the nurses are trained in this thing. So thank you for the presentation.
Thank you, sir.
One more comment. The Paralyzed Veterans of America,
Yes.
they have published this mainly for people who are looking after them in the community to do all these.
Yes.
It's not for physicians.
not
to
for
come in.
physicians.
Before they can actually encounter a physician, a lot of these things should be done. And so the PVA publication is mainly meant for that.
Yes.
Matthew was just saying that in the old days we used, and I think I've been out of action for some time, sublingual GTN. Yeah. So, yeah, GTN tablets, because that's often available in the ward as in the emergency drug. So, although the spray is not available, the sublingual GTN is.